I'm Ian Loftus, Professor of Surgery at St George's Hospital, University of London, and I'm here with Rodney White, Professor of Surgery from Harbour UCLA Medical Center, Torrance, USA. And this morning we're going to talk a bit about interventions in the ascending aorta. So welcome, Dr. White. You're investigating the use of endografts for intervention in the ascending aorta.
That's correct.
Can you tell us about that program of research that you're doing?
Yeah, it's brand new work that's obviously an expansion of what you see here going on in the show globally, but it's grown from the belly to the chest, now the ascending aorta, and it ties in very well with what's going on with the TAVI valve programs, so that the concept of a valve conduit and all those sorts of things go through people's mind very quickly when you start to tie together the technologies.
So which devices are you using for the ascending aorta?
Yeah, we have a specially designed product that Medtronic built and created a master file at the FDA, and then we have what's called a physician-sponsored IDE, where we handle the regulatory part and do the patients, but the manufacturers have the option to make the device, and it's a good program.
So the device is designed for that use, for the use of the
That's correct, specifically, so that certain parameters could be evaluated and then make it move on, hopefully.
Sure. And how many patients have you treated so far?
We've got 7 so far. It's a slow enrollment, but you can imagine these are very sick folks. Most of them have presented with a stroke. They've got severe sorts of problems, all the way from potentially an acute aortic dissection or a penetrating ulcer. They're very ill, so
there are a few other options available to them.
Yeah, that's correct. And this is really for patients who have no other good option, and we're trying to develop it so that the product doesn't always fail. I mean, it needs to move on, and so selection criteria are very important.
So selection criteria is important. And what other lessons do you think you've learnt since the program started?
Yeah, the anatomy is a little different in that the diameters are bigger. As you know, the compliance of the aorta is greater. And those were some of the questions the FDA wanted to answer first before we did anything else. Can you accommodate to those changes in a high pressure scenario right outside the heart? Can you do accurate deployments? Some very basic questions. So.
And how are you finding the program going, particularly for acute dissections, which are a real challenge for us, aren't they, in the ascending aorta?
Well, we're looking at that very carefully, and this gets into when you look at what's happening in this meeting, we're talking about hybrid rooms and how they've developed. That's what a hybrid room is all about. It's essentially a TAVI case upside down. We use all the same people, same instrumentation. You're looking at a CT scan, determining with the CT guys and the cardiologist and whoever else is involved whether that patient's an open candidate or not, and it really is a TEE right at the last minute.
So it's got to be a team process and done in the right environment.
That's correct, and have the right people there, because for a type A, you're going to go open or you're going to put a device in, and it's based on a TEE that's...
Okay, so decision is made at the time of intervention.
Yeah, correct.
And what have you seen long term in terms of remodeling for the dissections?
Yeah, it's the same. It looks like it's the same as the descending, where if you can look at the entry and re-entry sites, and I think we've all sort of seen how they remodel, so you can look at that, and if you can pick those, that's the challenge. Pick that group of patients, and if it were a high enough percentage, it might be you'd put an endograft in everybody, and then if it didn't work, that would be a stretch. But I think it has a chance to redefine the way we do current treatment and actually be a really good option for a big deal otherwise. So.
And you mentioned hemodynamics. It's a real challenge, isn't it, the ascending aorta? So any problems with graft migration so far, or problems with positioning of the...
Yeah, no, we haven't, and that's been a surprise in a little bit of a way, because we spent a lot of time with that. But we pace everybody. So again, it looks like a TAVI case. They've got pacers in when you cross the valve, or you get close to where your deployment is. We pace them. We even set the patients up to arrest them if we really have to have a moment where there's no movement at all. And you got to be that precise because you're right on the coronaries. And
so again, important to be in the right environment to do this. You do this all in a hybrid operating theatre.
Correct, yeah.
How important do you think is the high-end imaging for this sort of procedure?
Well, if you're saying high-end imaging in terms of X-ray, it's obviously we're all spoiled with really good state-of-the-art systems. So any one of those will do that. The other thing, though, that's very important is the ancillary imaging. TEE is critical. You got to have a cardiac TEE person who can give you the right images, make you be able to, look at it and decide what you're going to do. So.
And in terms of access, are you testing transapical route again along the TAVI lines?
The initial approval was for transfemoral because that's what the devices were built for. But because of the anatomy and then what we've learned with the TAVI cases also, that about 50% of those with what you call a horizontal heart or other angles involved in that, we requested and are approved for transapical delivery. So we haven't done one yet, but it makes sense and it's right. It's the same as a TAVI valve, and if you're looking to put it in the ascending aorta, it may even be better. And potentially for type A's, that's how you find the true lumens.
Sure. Now, so arch reconstruction is getting a lot of attention this year at the meeting, and you'll be presenting on this work. What do you think the main controversies in this area are in terms of moving it forward?
Well, the biggest one that we all sort of hide behind that's going to have to get resolved, though, is stroke. So it's up front with every intervention, and with these, particularly the ascending patients or the valve patients, they present with strokes. So they've got strokes, you create, this whole protection environment is going to have to evolve to impact a lot of technologies. It's low enough we can say, it's better than surgery or comparable, but it's got to get a lot better before we can be proud of it and say no,
So that's the big challenge.
That's one. Descending, obviously, paraplegia is the same. That's another one. We know how to get around it, but we don't know how to eliminate it. So
they're the important things for the patients, aren't they?
Yeah, well, those are the big consent items, yeah.
And just thinking about the meeting in general this time, you've been for a number of years, and this year there's a lot of emphasis on aortic work. We've got pretty much 3 full days of activities for aortic work, 3 days to peripheral topics as well, and a lot of venous. What do you think of the approach for this meeting?
Well, it's great. We were just talking about the facilities the way they are now. It's been adapted very well, and this is growing. It's a big meeting, but it's growing. The number of people that are involved in venous and peripheral and aortic, and the programs get bigger, within themselves, and then this hybrid room technology and everything that goes with that. So
a lot of discussion about imaging as well.
Very important. It's going to continue to grow, and it's a great forum for that. So Roger's done a great job of captivating the world. He's got people from everywhere here. So
And on that note, Dr. White, thank you for your valuable insights, and look forward to welcoming you back at Charing Cross 2016.
Thanks, Ian.